which is the main crux of today's class. Then necessary investigations which are required for diagnosis, and finally briefly looking at the possible treatments available for this particular condition. Now, starting with, remember these are the headings that we'll be going through, and this is what you need to know more or less about liver abscesses. For greater detail, you can always sort of refer to different research papers and other bigger textbooks. But in 45 minutes time, we will try to cover the major knowledge about liver abscesses. Now, simple definition of liver abscess, and definition which you can actually apply anywhere in the body wherever there is formation of pus. It is actually, so it is defined as it is the accumulation of pus which comprises of dead tissue of liver as well as dead bacteria. The bacteria can be both live and dead, as well as we know by our knowledge of inflammation that they are inflammatory cells as well. So it's a combination of dead tissue, liver, which is native, and then bacteria, which may be both live and dead, and the inflammatory cells. So this is how you would define a liver abscess. Then looking at the different types of liver abscesses, there are essentially two of them. One is a pyogenic liver abscess, and another one which is important in our part of the world, which is the amoebic liver abscess. Now, looking at the etiology and pathogenesis of a pyogenic liver abscess, usually it is unexplainable in most of the patients. There are times when somebody would have a pyogenic liver abscess, but we may not be able to identify the primary source from where this infection has arisen. But the origin of infection, if it is determined and it is clearly explainable, is usually from the gastrointestinal tract or the biliary tract with intra-abdominal sepsis. Now, the biliary tract condition can be biliary tract stones. I'm sure you must have seen gallstones and stones in the common bile duct, which can actually cause severe infections and can actually lead to these abscesses in the liver. Then diverticular disease of the large intestine, I'm sure you have some idea about it. These diverticular diseases, when they become complicated, they can form abscesses in the liver as well. There was a time complicated appendicitis, which was missed, can actually produce a similar picture in the liver, forming abscesses there. Now, the incidence is known in many patients, but there is increased incidence in elderly patients, patients who are diabetic, and patients who are immunosuppressed or immunocompromised, either because of the disease that they have, or they may be on some immunosuppressant therapy, being treated for HIV or being treated for cancer treatment. These are the patients who are vulnerable to develop these abscesses. Now, as far as the amoebic liver abscess is concerned, its etiology and pathogenesis, it's endemic in many parts of the world. And Indo-Pakistan is one of the areas where the amoebic liver abscesses is endemic. We see it quite frequently both on the medical and the surgical level. Now, the causative organism is Entamoeba histolytica. The route of infection is fecal oral route. That means the food that we eat has to be contaminated with Entamoeba histolytica, and the subsequent events which take place once the Entamoeba histolytica enters the human body is that the amoeba cyst is ingested in the food. It forms trophozoite forms in colon, and from the colonic wall they pass through the portal circulation, and through the portal circulation they obviously reach the liver. Once they reach the liver, obviously they can actually produce these abscesses with the inflammatory response over there and subsequent accumulation of pus. The microorganisms which are usually involved in case of these liver abscesses are the most common ones are the Streptococcus malariae and Escherichia coli. These are the two most common organisms. Besides these, the lesser common organisms which can be identified in these liver abscesses are Streptococcus faecalis, Klebsiella, Proteus vulgaris, and then there is Staphylococcus infection as well, which is especially seen in patients who are immunocompromised. So if you can remember these these few names of microorganisms which can cause, and remember all these microorganisms cause pyogenic liver abscesses. And just to cover up the whole list, you can add Amoebic salitica, as we saw that this can cause amoebic liver abscesses. Now, the clinical presentation, whenever we talk about clinical presentation, we basically look at the symptoms and the signs. Now, as far as the symptoms are concerned for liver abscess, there would be pain in the right upper quadrant for obvious reason where the liver is. There is associated fever, which can vary from a low grade to a high grade fever, with chills and rigors as well. Then there is a general malaise. It's a general constitutional symptoms whenever you have infection in your body. We have all experienced the general malaise. Not necessarily everyone had a liver abscess, but we know that when we have infection in our body, it actually causes a general malaise, a general feeling of lethargy, a general feeling of not feeling well, being unwell. There is anorexia, that is loss of appetite, and many patients, especially patients with amoeba histolytica, can have diarrhea. Now, as far as the clinical presentation in terms of signs is concerned, whenever we talk about signs, the first thing that we comment on is the general physical appearance of the patient. Then following the general physical appearance, we look at the vitals, then we may look at the general physical examinations, and then we go on to specific examination of the abdomen, especially if we are looking for a liver abscess, or then a general systemic examination that can give you further signs. So as far as the general physical appearance of these patients are at times very ill looking. And depending on the degree of sepsis that they are actually facing, they may have altered mentation. That is, they may or may not be oriented in time, space, and person. So the degree of illness of these patients greatly depend on the degree of sepsis they have and the duration that they have actually remained untreated or undiagnosed. So, but when there is a severity of infection, these patients are quite substantially ill. Now, as far as the vital signs is concerned, the blood pressure can actually be a normal, it can be increased because of the increased catecholamine secretion, or it can be low, that is, the patient can be in a state of shock. By and large, pulse would be on the higher side, patient would be tachycardic, and the temperature is, as mentioned, that it will be febrile from low grade to high grade fever, and the respiratory rate, usually these patients are decapitated. Now, as far as the abdominal examination is concerned, they would have tenderness in the right upper quadrant, and if one can generally examine these patients, one can actually identify the boundaries of the enlarged liver, which would obviously be tender. These are the findings based on the symptoms of the patient and based on the signs. These simple signs can actually give you a differential diagnosis that this patient may be suffering from a hepatic abscess. Now, as far as the investigations are concerned, there are essentially two sets of investigations that we look for. One is the laboratory investigations, and the second one is the radiological investigation. Now, as far as the laboratory investigations are concerned, we will look at only the specific ones, very specific, that would help you in making a diagnosis or treating these patients. The first and the foremost is the complete blood count. Now, in complete blood count, you look at the hemoglobin, whether the hemoglobin is normal or whether it has been reduced because of sepsis. You would like to review the total leukocyte count, that is the total WBC count. By and large, in patients with hepatic abscesses, both in pyogenic and amoebic, these white cell counts are raised, and there would be a predominant neutrophilia, suggesting of acute infection. Now, another investigation that you would like to do is the blood sugar random, just to exclude the possibility of diabetes if the patient is already not known diabetic. At times, you will identify or discover diabetic patients when they suffer from some infection, and when they get investigated for those infections, you come to know that this patient is a newly diagnosed diabetic patient. Now, blood cultures are always sent in patients who are febrile, just to check for if there is any growth of microorganism in the blood that helps in making a diagnosis and subsequent treatment. Then pus culture and sensitivity should be sent, and this is obviously collected from the liver. You'll shortly see that how they can be collected. There was a time it used to be collected blindly by putting in needles into the liver, but now we have image available, we have experts available in the radiology department, which can actually help us in collecting these pus. And once this pus specimen is available, then that pus can be sent for culture and sensitivity so as to identify which organism is growing over there and what are the antibiotics to which this organism, or if there are more than one organism, is sensitive. Now, one can actually do isolation of the parasites from the liver or stool as they are studied under the microscopy, under a microscope, especially in case of amoebic liver abscesses. If they are retrieved, then these parasites can be isolated and they are diagnostic in cases of amoebic liver abscess. Another test which is done, which has been done for many years, it is the indirect heme agglutination test (IHA), indirect heme agglutination test for Entamoeba histolytica. If we look at the titers of the immune histochemical response, the immune response created by the Entamoeba histolytica, and the levels are judged in the blood. And if they are raised, then that actually gives the impression that this patient has got an amoebic liver abscess. Now, as far as the radiology is concerned, the first and the foremost, obviously, is the ultrasound, which is a non-invasive test, and it's pretty sensitive in picking up these abscesses in an expert's hand. It can actually show the presence of an abscess in the form of a unilocule, or it can be a multilocular appearance abscess that bring multilocules in it. And then at times it can be a solitary abscess, or it can be a multicentric abscess. That is, there are small abscesses which are present in both right and left lobe of liver, and there is no communication between them. Now, the next investigation, which is available in radiology to investigate these patients, is the CT scan. Now, CT scan abdomen with contrast, since it is operator independent. Remember, the ultrasound is operator dependent. That means that the findings of an ultrasound can vary from one person to the other depending on the expertise. But in case of a CT scan, which does not depend on the operator, it can be read and it can be interpreted by most of the radiologists and the clinicians, and the discrepancy between the reports is minimal as compared to the ultrasound. So it is an operator independent, and it is likely to give you more accurate report as compared to the ultrasound. Now, besides this, it can also give more information about the possible source of pyogenic abscess. This is for the CT scan. If there is, let's say, for example, a diverticular disease which has created a complication, or if there is a biliary disease there which may or may not be picked up by an ultrasound, or if there is a complicated appendicitis, it can give you the finest details about it. So a CT scan has a far more accuracy in determining the nature of the abscesses, as well as at times helping us in identifying the primary source of infection. Besides that, it can also comment on the colon, like in patients with amebiasis, the colon, as we know, can actually be infected, and we also know in case of the diverticular disease, the sigmoid diverticular disease, with the help of the CT scan, one can actually comment on the nature of the colon as both in case of amebiasis and in diverticular disease. So comparing ultrasound and CT scan, a CT scan is a far more sensitive test as compared to ultrasound. This is one of the pictures that you probably see in patients who have abscess. And this is a CT scan. You can actually see the presence of a lesion in the right lobe of the liver, which is actually got a little bit of enhancement going on around it. This is a classical picture of a solitary abscess which is present in the right lobe of the liver. Another example is example of a multilocular abscess, which is again present in the right lobe of liver, which is a pyogenic liver abscess. You can actually see little, septated area, but very clear demarcation, and is not the same liver texture that you will see in the surrounding area in the right lobe. And this is a classical picture of a multilocular abscess, especially in cases of pyogenic abscess formation in the liver. Now, as far as the treatment is concerned, uh, for amoebic liver abscesses, usually the treatment is tablet metronidazole, which is commonly comes with the name of flagyl. It is given in the dose of 400 to 800 milligrams 3 times a day for 7 to 10 days. In case of pyogenic, we know depending you have to give broad spectrum antibiotics depending on the preference of the individual clinician or the known sensitivities that are prevalent in that part of the world. Or you can be more accurate by collecting the pus from the liver and then treating them therapeutically after receiving the cultural sensitivity. The different antibiotics which can be used include the penicillin group, the aminoglycosides, the thalasporins, metronidazole can be added to it, and then going on to much more potent antibiotics in the carbapenem group or the tazobactam group. Now, these are the antibiotics, the pharmacological agents which are used to treat abscess, these liver abscesses. Now, other than that, another methodology is image-guided drainage of the abscess. There was a time about 30 years ago or so, these abscesses used to be drained surgically. But with the advent of interventional radiology, surgical drainage has become obsolete. And especially in cases of pyogenic liver abscess and even amoebic liver abscess, where it is considered that they should be drained, then they are drained through image guidance. So a lot of improvement and a lot of patient compliance improved when the radiologist was able to drain these abscesses. So, and it is done most commonly with the ultrasound under the ultrasound guidance, but occasionally CT scan may be required for an appropriate drainage of these abscesses. Now, once the decision is taken to drain these abscesses, the drainage can be done in a single time, or if required, it can be done multiple times if one finds that the abscess is not completely liquefied, and that may take some time once the pharmacological agents are introduced. So there are times when these these abscesses are drained multiple times. And if the radiologist believes that there is a large cavity of an abscess, then instead of draining it multiple times, they can actually place in a pigtail catheter. It's kind of a drainage catheter which is left in the abscess cavity, and it continues to drain either through passive drainage, or you can actually do an active aspiration of these abscesses from this cavity once the pigtail is placed. Okay. In case of pyogenic, underlying etiology, if identified, should also be treated. As you mentioned that in case of pyogenic liver abscesses, this could be because of a complicated diverticular disease or a biliary tract disease or a complicated appendicitis. So if there is a pyogenic liver abscess and if the primary source is identified, then that has to be treated as well. Okay. Thank you very much. If there are